Right. Hello, everyone. Thank you for joining today. My name is Isaiah Brown, and I'll be moderating today for Dr. Octavio Arevalo Espejo. He is an assistant professor of radiology at Louisiana State Health, Shreveport, and his specialty is in neuroradiology. We'd like to welcome him, and today we're going to discuss imaging of gliomas in 2022 and review the WHO CNS5 classification system. Thank you.
I think I was muted. Thank you very much, Dr. Brown, for your kind introduction. And I want to start saying that it is a great pleasure and honor for me to be sharing this time with you all. If you have any question during the meeting, I cannot see my chat box, but you can type in there, and then at the end of the session, I can address the questions. So today I'm going to be talking about the imaging of gliomas in 2022, and specifically all the topics regarding the new classification of the World Health Organization. And I have to disclose that I'm not a neuropathologist, and the full depth of the topic is way above my head. But I'm gonna try to relate these pathological concepts into the radiology practice, and I'm gonna try to show you the imaging appearance of one of the a few of the new entities that are included in the new classification. So I have no disclosures. The objectives for the lecture are mainly three. The first one is to understand the rearrangement of the glioma family trees. And this is being based on the integrated histological and molecular diagnosis. And to get to understand the most important and relevant molecular abnormalities, is to identify scenarios where we as radiologists may be able to help with the pre-operative diagnosis of these patients. So just a very rapid slide about history. This is the first classification of the WHO of brain tumors. This is back in 1979, and this was basically histology. And then later in 1993, this is the second edition. And in this edition, they introduced some of the early immunohistochemistry techniques for better refine the diagnosis of brain tumors. And this is the third classification in 2000. And here you can see that they already include a little bit of a glimpse of these advanced molecular techniques like genotyping and FISH, as you can see it here, but it was just like an ancillary information that was not needed for the actual diagnosis. This is the fourth edition of the brain tumor classification. And here you can see that there is a glimpse of the new techniques here, like electron microscopy and methylation profiling and all these advanced techniques. And if you take a look at this panel down here in the center down, you will see that there is a mention of metabolic pathways, that are abnormal in certain brain tumors that were taken into account when defining the entities. However, it was until 2016 when not a fifth edition, but a 4+ edition was issued, when the molecular abnormalities took a protagonic role in the diagnosis of brain tumors. And we had been working with this 4+ edition until 2021, when the formal fifth edition of the classification of the brain tumors was published. The actual book was published in January 2022. And I want to give you just a brief overview of what it's all about. So before starting, I want to talk about some basic cornerstone histological features in diffuse gliomas. And I want to emphasize that I refer to diffuse gliomas only. We are not talking about circumscribed gliomas here, which are a different business, okay? So diffuse gliomas usually start at the grade 2 histological level, and the grade 2 is when you see a hypercellular piece of brain parenchyma with presence of glioma cells, by default, it is a grade 2. But if you get some features, histological features of anaplasia, cellular anaplasia, and mitotic activity. If you get any of those plus the glioma cells, then you are in front of a grade 3 diffuse glioma. But if besides any of these, or perhaps only if you only find microvascular proliferation or necrosis, if you find any of these two findings in histology, automatically it bumps it up to a grade 4. And you're going to get the PMIDs here just in case you want to get into those specific references. So the new classification proposes a layered pathological report structure. And what that layered means is that they propose 4 layers of information in the final pathological report that we as radiologists have to be familiar with. So, and the first layer, the first and top layer is the integrated diagnosis. And the integrated means combined tissue-based histological features and molecular features. So this is the integrated diagnosis. The second layer is the histological diagnosis. And the third layer is the grade. And I want to bring your attention to this because the new classification proposed these Arabic numerals instead of the Roman numerals for the brain tumor classification. So there is no confusion with the letter I on some genes, so they propose, to use like this Arabic numerals from now on. And the fourth layer is the molecular information relevant for the specific integrated diagnosis. So this is an example, for example, of a pediatric tumor. This tumor is now called diffuse low-grade glioma MAP kinase pathway altered. That is the integrated diagnosis here. However, the histological diagnosis is a oligodendroglioma, an oligodendroglioma. And you may say, why? Why won't you just call it oligodendroglioma? And the thing is that this is a pediatric type of tumor. And pediatric oligodendrogliomas or pediatric oligodendroglioma-like tumors by histology have a different molecular footprint and a different biological behavior as the oligodendrogliomas of the adult. And we'll take a look into that closer. And the grade, the CNS5 grade, is not assigned to this tumor because it hasn't been determined yet by population studies, depending on prognosis, etc. And the molecular information, because if you say here, this is the diagnosis, MAP kinase pathway altered, but this is the specific abnormality of the pathway. So it's a duplication of the FGFR1 tyrosine kinase domain receptor. So what if an integrated diagnosis based on the CNS5 WHO classification cannot be obtained? What if you don't have the information to fill in the blanks of these 4 layers? Then the final diagnosis will be a combination of the histological diagnosis and whatever else you have, the additional data available, followed by one of these acronyms. And what does it mean, NOS or NEC? Let's take a look. This is a diagram from one of the Dr. Lewis lectures. He is the chief neuropathologist of the WHO task force. And he uses this traffic light cartoon to teach the different concepts of NEC and NOA. So you have the green light when you have an integrated diagnosis, when you have the combination of morphological and molecular information that allows you to put your tumor in one of those big categories. So you are good to go. You have to use the NOS or not otherwise specified when you don't have relevant molecular information because the tests were not available or were not performed or were not successful. You have the tissue, but either you don't have either the immunohistochemistry, next generation sequencing, and all these fancy tools in your hospital. So this is what your neuropathologist is gonna give you in the pathology report. So when you see your report and you see this NOS, now you know that this is a tumor diagnosis based on the histology only, because these other tests are not available. Now, there is a intermediate category, which is the NEC, and is not elsewhere classified. And these are the zebras, okay? These are tumors that you got the full workup, but the results that you got do not allow you to classify this tumor in one of the CNS5 categories. So this is another acronym that you are going to find in your pathology reports, and you have to be familiar with. So this is perhaps the most important slides of my lecture. These are the molecular alterations that you have to know as a neuroradiologist when you are reading these oncology cases. So you are familiar with the lingo, and when you are presenting tumor board, then you know what the neuro-oncologists and neurosurgeons and neuropathologists are talking about. So perhaps the most important one is the isocitrate dehydrogenase mutation, which is the center, of this kind of engine that I try to draw here. The IDH mutation, and based on this mutation, you will have, the other, mutations, so the other abnormality is the 1p19q co-deletion, which is important for the diagnosis of oligodendroglioma, aka adult oligodendroglioma. The CDKN2AB homozygous deletion, which is important for the IDH mutant disease, and the histone 3 abnormalities, which are important in pediatric gliomas. And these three guys, the third promoter mutation, the GFR gene amplification, and the gain of a whole copy of the chromosome 7 and a loss of a whole copy of the chromosome 10, that this combined abnormality, these are important for IDH wild type disease, and we'll get into that real soon. So the new classification groups the gliomas in 4 groups. However, for me to be like easier to explain it, I just group it in 3 groups. So this is the adult type diffuse gliomas, the pediatric type diffuse gliomas. These can be classified in low grade and these high grade. These are the four groups, and then the circumscribed astrocytic gliomas. So there are, you can understand it in a 3 groups way. So I think it's easier. So let's talk about the adult type diffuse gliomas. This was the 4+ edition in 2016. And you see that we had here like roughly 15 different entities of gliomas. In the new classification, 2021, there are only 3 tumor types, only 3. Oligodendroglioma, IDH mutant, and 1p19q co-deleted. The whole thing is one single name. It's like my name. I have 5 words in my name. So I have 3 given names, 2 family names. So it's a long name. The whole thing is the name of this tumor. And the other entity is astrocytoma, IDH mutant, and the other entity is glioblastoma, IDH wild type. And we'll get into it. So you have, let's say that you have an adult type diffuse glioma. The next step for you to determine what tumor is, it is not the histology anymore. It is not the histology anymore. It is the IDH status, the isocitrate dehydrogenase status. So is it mutated or is it wild type? And this step is usually sorted out with a very cheap, let's say, immunohistochemistry technique. You do not need next generation sequencing for this. So this is just like why I think that is already widely available, at least in the United States. So then you have 2 groups. You have IDH mutant adult type gliomas or IDH wild type adult type diffuse gliomas. Now, What happens with the IDH mutants? Then you take a look into the histology business, okay? And then you may have a tumor that looks like astrocytoma, or it looks like an oligodendroglioma, you know? So at this point in the past 10 years, you had a tumor that used to be called oligoastrocytoma, which was mixed histology. That entity is not an entity anymore since 2016, and more so with the new classification 2021. So if you have the histology for oligo, then you have to check, you have to test for the 1p19q co-deletion. If you have it, if you have the 1p19q co-deletion, it means that you have these two molecular abnormalities already, the IDH mutation and the 1p19q co-deletion. When you have those two plus the oligo-like histology, then you have to check for features of anaplasia. You remember our first slide, either mitotic activity or anaplasia. And depending on these features, on these histological features, you grade it as grade 2 or grade 3. So the diagnosis is going to be oligodendroglioma, IDH mutant, 1p19q co-deleted, grade 2, okay? But what if the tumor has an astrocytic morphology on histology? Then you have to check for these other two mutations, the ATRX and the P53. So if the patient does not have these three, you got to test for the 1p19q co-deletion, okay? And you may say, well, why don't you get the 1p19q co-deletion for all the IDH mutants? And the thing is that this is expensive, okay? This is a fish technique, and it's worth like a couple $1,000s. So if you don't have to do it, then you just go and check for these ones that are immunohistochemistry, aka cheap techniques, okay? So now, if you have the ATRX and TP53, this is the triad of the IDH mutant disease. The IDH mutant astrocytomas, IDH mutation, ATRX loss, and TP53 mutation. Once you have confirmed that you have a tumor that looks like an astro and has these molecular abnormalities, then you have to check for the histological features, either mitotic activity, anaplasia, microvascular proliferation, necrosis. Remember, these guys bump your tumor up to grade 3, and these guys bump your tumor up to grade 4. Remember? But now there is a new player here, which is the CDK N2AB homozygous deletion. The CDK is a cyclin-dependent kinase. This isoform N2A and N2B, you know, when you have a homozygous deletion of that gene, then by itself, regarding the histological features, by itself, it bumps the tumor up to grade 4. So this is very important because here you can see that a single molecular abnormality that cannot be seen by the naked pathologist eye will automatically upgrade the tumor to a grade 4, regardless the absence of microvascular proliferation or necrosis on histology. So here you can see that we have 3 possible categories: the astrocytoma IDH mutant, which is this tumor with no upstaging features. If you have a grade 3, then you will have this tumor plus either mitotic activity or anaplasia, and a grade 4 if you have microvascular proliferation, necrosis, or the CDKN2A or 2B homozygous deletion. And you may say, wait a minute, astrocytoma IDH mutant grade 4? Yes, this is one of the big changes to the 2016 classification, because this is the guy that used to be called glioblastoma IDH mutant. The glioblastoma IDH mutant term is not a thing anymore with the new classification of the brain tumors. So this is one of the big changes. Now, let's go back. We have an adult type diffuse glioma, which is IDH wild type. So then we will have to check for either all the grade 4 features, microvascular proliferation, necrosis, or EGFR amplification, a gain of a whole copy of the chromosome 7 and loss of a whole copy of chromosome 10, or the third promoter mutation. If you have any of these 5 items, any of those, regardless of the histology, then you have a glioblastoma. Now, you may have a tumor that by histology, does not have microvascular proliferation nor necrosis by histology, but the mere fact of having any of these 3 molecular abnormalities, any of those, it is automatically a glioblastoma, period. Okay, so, and this is very important because that might be looking a grade 2 histology looking glioma, but you have to treat it as a glioblastoma, okay? But what if it is an IDH wild type tumor that doesn't have any of these features, any of those? Then I put this in a dotted line. Then you have to call it a diffuse astrocytic glioma, IDH wild type, not elsewhere classified. And there is, you see these little acronyms pop up in the new classification. And this is a working diagnosis. This is a temporary diagnosis because this tumor, which is IDH wild type in an adult that doesn't have any of these, may be a pediatric tumor popping up in an adult patient. So these features highlighted here in yellow are the ones you know, that are upstaging features. So this is what I already said. So we are radiologists. We like pictures. You know, there is nothing more boring than a paper without pictures. So this is a patient. This is a 48-year-old male patient. And the survival was 17 months. And based on the 2016 diagnosis, this was called an anaplastic astrocytoma, IDH wild type, WHO grade 3. You see that? Grade 3 by histology. And this is an IDH wild type. And you know that for IDH wild type disease, you only have one option, which is grade 4. And look at this. This tumor had an EGFR amplification and Peter promoter mutation. And then as per the 2021 classification standard, just by the mere fact of having these molecular abnormalities, this tumor is called glioblastoma. Now let's take a look into the images. If you take a look at, this is the axial flare, you see this mass-like T2 flare hyperintensity at the medial temporal lobe, you know, that did not show any enhancement or necrosis by imaging at all. Didn't have any areas of like massive restricted diffusion, you know, to think of hypercellularity, no hemorrhage or calcifications on the susceptibility weighted images, and no increased perfusion on the perfusion ASL without contrast and dynamic susceptibility contrast, which is contrast perfusion. So if you take a look at the MR spectroscopy of the same tumor, you see that there is no like a significant calling to creatinine or, you know, or calling to NAA ratios, maybe a little bit here, but nothing like super crazy. So this is what, you know, I would have read as a low-grade glioma in the reading room. And I could have been right before 2016, you know, but again, you know, so this is just to give you an eye opener on how the new classification, you know, is going to impact our reads. You know, this is a glioblastoma, and this is what now, you know, we understand as glioblastoma based on molecular profiling. And take a look at this case. This is another MRI. This is a 31-year-old male, survival of 4 years. And the 2016 diagnosis was an astrocytoma IDH mutant and WHO grade 3, you know. But if you take a look here, as per the 2021 standard, this patient had this homozygous deletion, which is the CDKN2AB homozygous deletion, which bumps it up immediately to a grade 4. And you see, this is a tumor that is T2 flare hyperintense, centered at the right paracentral lobule. You see that there is no enhancement in the T1 post-contrast images. There is no restricted diffusion, hemorrhage, or calcification. This looks like a low-grade glioma as well. And the survival was pretty short for a patient with IDH mutant disease. So what is this CDKN2AB business? So this is a cyclin-dependent kinase inhibitor, as I told you. And this encodes for many proteins, including the P16 and P14, which are, tumor suppressors. So if you have a homozygous deletion, then you are you are off, of tumor suppressor genes. So that is very important. So, and the prevalence of this abnormality in IDH mutant tumors is very high. For example, for histological grade 2, up to 12% of these tumors that are very benign looking on histology may have this homozygous deletion, and grade 3 up to 20%, and and the histological grade 4 IDH mutant up to 34%. So this is something that is very important. Here, this is a Kaplan-Meier plot for patients with IDH mutant disease. This is a very, very beautiful paper by the Heidelberg group that shows here you have astrocytoma grade 2 by histology, grade 3 by histology, and GBM by histology. Remember, this is a paper from 2018, so they didn't have this astrocytoma grade 4 business in the past. And you see that based on histology, the patients with the higher grade die faster, right? But now when you discriminate the groups based not only on the histology, but also the presence of the homozygous deletion, I want to bring your attention to this group. If you compare the grade 3s with the grade 4s with normal CDKN2AB, you will see that if you have a grade 3, which is this guy here, with the homozygous deletion, the patient is going to get a very worse prognosis than a grade 4 by histology without the homozygous deletion. So that is why this guy is very important, and you're going to start seeing it like more often in your pathology reports. This is perhaps one of the most influential findings in the recent oncological neuroradiology, and is the T2 flare mismatch sign. It was described by Dr. Rajan Jain from NYU a few years ago. It was in 2018. And here what you see is that there is a tumor that is very bright on T2, and it has partial suppression of signal on the flare images, but not to the point of the CSF. You see that? It's darker, but it's not as dark as the CSF. So this partial suppression has a specificity of 100% and a sensitivity of 42%. Is not that good for astrocytomas IDH mutant in the adult population. This is a very, very beautiful meta-analysis published in European Radiology in July 2021. This was authored by the South Korean group, and they pulled like a few hundred of these patients published in the literature, and they found out that the specificity was super high. So you have to know this. If you see this, you can say in your report in an adult, you can say in your report, the findings are consistent with an astrocytoma IDH mutant. So this is very interesting. So those were the adult type of tumors. Now let's move on to the second category, which is the pediatric type diffuse gliomas. So here you have the low grades and the high grades. In the low grades, you have 4 entities that feature diffuse growth in the brain, but with overlapping histological features. That's why you know, this is one of the scenarios where the integrated diagnosis is more and more important. So the molecular workup helps to better characterize those lesions, given that the histology is sometimes equivocal. So there are a few new tumors like the diffuse astrocytoma, MYB or MYBL1 altered. This is a new tumor, the polymorphous low-grade neuroepithelial tumor of the young, abbreviated as PLENT, the angiocentric glioma, and the diffuse low-grade glioma MAP kinase pathway altered. This is perhaps the most stunning change to the classification, because remember, we are talking about kids here, pediatric type. So in the kids, we only call diffuse low-grade glioma with abnormalities of the MAP kinase pathway with astrocytic morphology or oligodendroglial morphology. And you say, hey, why don't you just call it astrocytoma or oligodendroglioma? And it is because these guys do not play by the rules of the IDH mutation. So these oligodendrogliomas of the kids do not have the IDH mutation and 1p19q deletion, even though they have the oligodendroglial morphology. And the astrocytomas of the kids, all of them are IDH wild type, and they do not behave as glioblastoma. So that's why if you have an IDH wild type glioma in an adult that doesn't meet the criteria for glioblastoma, then you have to take a look into the astrocytic morphology tumors of the kids. So this is very important for you to understand that. So, and now take a look at the high grade group. So it also includes 4 entities that share some of the common histological features such as necrosis and microvascular proliferation, but the cornerstone molecular abnormality here is the histone gene alterations. So this is very important for you to keep in mind. So here we have the very well-known diffuse midline glioma H3, histone 3, K27 altered. We have here the diffuse hemispheric glioma H3G34 mutant, and this guy is midline, and this guy is hemispheric glioma. And both of them have a histone abnormality, a histone 3, but this guy is in the position number 27, and this is in the position number 34. There is another one, which is the diffuse pediatric type high-grade glioma, H3 wild type. What wild type means is that H3 normal and IDH normal as well. So this is the one that used to be called pediatric glioblastoma. So this is another of the changes. And then we have an infant type hemispheric glioma, which is very aggressive as well. So the term glioblastoma is no longer used in the setting of a pediatric type neoplasm. And again, it will take some time while this classification permeates the clinical practice in our countries, but it's good, that you guys understand what the changes are. So let's take a look at the flow chart. So you have a pediatric type diffuse glioma. In kids, histology is still the first step. So then you have to differentiate between low grade and high grade depending on the histological features, and then depending on the age of the patient, location, histologic phenotype, and you get a tailored testing. You're not going to test for every single gene on these patients, but then you can classify the tumors depending on these 4 benign entities. And then if it's a high grade, again, same story, and you test for these type of mutations, the IDH mutation as well as the histone 3 mutations, and then you get this 4 entities as well. This is just what I already talked about. So let's talk about the low grades. Let's talk about the low grades in kids. I'm gonna show you a couple of cases, So you can take a look at what these new entities are about. This is a patient, a 22-year-old female patient with complaining with disorientation spells. And here you see that there is a T2 flare, hyperintense mass-like lesion at the left anterior temporal lobe that shows a little rim of of enhancement around a central area of calcification that you can see here in the SWI. You see that? And there is no associated restricted diffusion. I mean, if you have a young patient with a mildly enhancing cortically based tumor of the temporal lobe that is ceasing, the first thing that comes to mind is an oligodendroglioma, right? Like these PDOC mnemonics. However, the difference is that this tumor has a very specific molecular profile, you know, and the difference is that this is a WHO grade 1 tumor. And by saying that, it means that if you resect it, you cure the patient. Whereas an oligodendroglioma per definition is at least a grade 2 tumor, you know, and you need to either, you know, there are different type of treatments, like only resection. There are some people that also do radiation, PCV, chemotherapy. Is a different type of tumor, is a different prognosis, even though on imaging they look very similar. So this is what a plenty looks like. So if you haven't seen any before, there you go. This is a patient with she is a 22-year-old with history of seizures again. And you see that there is this expansile T2/flare hyperintense lesion. You see that there is bone remodeling here. So this tumor has been slowly growing there for a while. There is no enhancement whatsoever, no restricted diffusion, and there is no calcification. And this is what an angiocentric glioma looks like. And again, this is a WHO grade 1 tumor, a benign tumor, okay? Same story here. This is a patient with headaches, 12-year-old. She was found to have this non-enhancing lesion of the left cerebellar white matter with no enhancement, no restricted diffusion, which was something that is reassuring in a pediatric tumor of the posterior fossa. And again, this is an angiocentric glioma in the posterior fossa. Now let's talk about the high grades. So the high grade tumors, you know, as I told you, the histone 3 abnormalities are the main driver. So I want to show you this little graph. This is again from the Heidelberg group. Very nice paper from 2012. It's a kind of old paper, but still like very, very valid today. So they compare the different patterns of DNA methylation, which is something that is very hot topic these days in brain tumors, the tumor location and the patient survival for IDH mutations, for mutation of the position 27 of the histone 3 and the position 34 of the histone 3. And you will see that, you know, for the IDH mutant disease, which is, you see that the peak is here between 30 and 60-year-old. You see that this is the bulk of the age, you know, of these patients with IDH mutant gliomas, and you see that they are overrepresented in the frontal and temporal lobe. Those are supratentorial tumors. You see that, and the survival, you know, gets to 120 months, which is a lot, you know, for these patients since the diagnosis. Now, if you take a look at the H3 K27 altered tumors, you will see that these patients' age is usually kids, but you can see patients up to the age of 30, early 30s with this type of pediatric tumor. So if you have a 35-year-old with this tumor, that 35-year-old is not a kid like anymore by social standards, right? But you know, you have to bear in mind that this patient may well have a pediatric type tumor. And look at this. This tumor is located all the way down in the midline, you know, from the septum pellucidum, like diencephalic structures, midbrain, brainstem, and spinal cord. That's why this tumor is no longer DIPG. Its name is no longer DIPG, diffuse intrinsic pontine glioma, because it's not in the pons only. It happens everywhere in the midline. And look at the survival, very poor survival, this tumor, and this is the hemispheric glioma, hemispheric type of pediatric glioma, which is an H3G34 mutated. And then you can see that the location is also hemispheric, but it's more of a parietotemporal tumor. And the survival is a little bit better than the midline guy, but again, the survival is poor. So let me show you some pictures. This is a 40-year-old female patient with a survival of 17 months. And the WHO classification of the 2016 already said that this tumor's name was diffuse midline glioma, H3K27 mutated. The DIPG term was obsolete by 2016, but the new classification calls it altered. Because there is not only mutation, but also another set of molecular abnormalities that makes this histone to malfunction. So, and you take a look, this is a tumor that is centered in the midline, in the pontomedullary junction. There is no enhancement, and you see that the pons is just like a victim here, because the tumor is primarily located in the medulla oblongata here. And you see that this has a mild restricted diffusion due to the hypercellularity, but there is no hemorrhage or enhancement whatsoever. This is what a diffuse midline glioma looks like in the medullary, in the medulla oblongata. And you can see the choline to creatinine ratio in MR spectroscopy and the choline to NAA, which are very worrisome due to the high grade of this tumor. And this is a very interesting case because this patient has a history of a congenital agenesis of the posterior arch of C1. Therefore, the patient got a chronic subluxation of the atlantodontoid joint and this retroflexion, congenital retroflexion of the dens. And the patient was complaining of tingling of the upper extremities. And you can see by the spine that this is a young patient. This is a young patient. This is in early teens patient. And you see that this patient got an MR of the cervical spine without contrast, And the radiologist that first read the MRI said, okay, there is a stenosis here in the craniocervical junction. Therefore, this patient has a syrinx of the cervical spinal cord, which is reasonable because you see that on the patients with carry-1 malformation, right? So, but if you take a look, this signal intensity is not the same as the CSF signal intensity here. It's a little bit more massy. So the patient went to have an MR of the cervical spine with contrast, and you see these areas of enhancement within the mass lesion. So this is the axial plane of the same patient, and this is, again, a diffuse midline glioma H3K27 altered, now in the cervical spinal cord. This is a patient, a 33-year-old female patient. Again, I'm showing you these patients in the gray area. And this patient has this diffuse multicentric T2/flare mass-like hyperintensity involving the left frontal and temporal and parietal lobes, but there is no restricted diffusion, no enhancement, no hemorrhage or calcification. This is the perfusion without contrast ASL, no increased perfusion that you can call. You would have read this as a low-grade glioma with a gliomatosis cerebri pattern of growth. You see that the tumor is also here in the insular region, the thalamic region, and the same features in contrast and perfusion. Well, this patient was biopsied, and the diagnosis, as per the 2016 standard, was an anaplastic astrocytoma, IDH wild type, W2 grade 3. IDH wild type, wait a minute. You don't call IDH wild type disease unless you have all these 5 things that I show you, Because you have to make sure that this is not a glioblastoma. Well, they ran all those tests, and those tests were negative for adult glioblastoma. So they said, well, this patient is a 33-year-old. Let's check out for the histone mutations, because this may well be a pediatric type of tumor in an adult patient. And guess what? This is what a diffuse hemispheric glioma of the kids, which has the mutation of the H3 G34 position, looks like on MRI. So it's very hard for you to call it just on MRI, but you have to know that this pediatric entity exists in adults. And guess what? Look at this. This patient has this peak of myoinositol, and the ratios here are not very spooky at all, you know? So you may in the past we were taught that the myoinositol peaks were a marker of a low-grade tumor, and you may be right, because by histology this relates to the histology of a low-grade tumor, but this doesn't relate anymore to the molecular diagnosis of tumor, which indeed correlates better with prognosis and survival. So let's talk a little bit about circumscribed gliomas. This is the last thing I'm gonna chime in on today's lecture. So it didn't change a lot. The old and good pilocytic astrocytoma, PXA, SEGA, you know, all these guys that we are familiar with, you know, but you know, there are a few new players here. And by circumscribed gliomas, in our minds, you always have kind of benign tumors. But there is a new player here, which is called the high-grade astrocytoma with pyloid features. So, and I want to talk a little bit about this new guy. So let me show you a couple of cases. This is a 21-year-old male patient with headaches. And you see this kind of multi-cystic subcortical tumor that shows like some areas of linear enhancement and solid enhancement with a lot of edema, you know, in a young patient with no restricted diffusion, no hemorrhage or calcifications. You know, this is very hard to call based on MRI, but you know, this is what astroblastomas look like, which are one of the circumscribed gliomas, and these are a grade 1 type of tumor, astroblastoma. And I want to show you this very interesting case, because this is an MRI of a 35-year-old male patient presenting with headaches. So if you take a look, this is a very ill-defined, homogeneously enhancing tumor centered at the vermis of the cerebellum. But if you pay attention here in the sagittal post-contrast, there is leptomeningeal enhancement, you know, that is outlining the cerebellar folia here. There is no restricted diffusion, which is the hallmark of the malignant neoplasm of the kids in the posterior fossa, and the enhancement is very avid. I remember when I was a fellow back in Texas Children's, my teachers used to tell me, hey, whenever you see a pilocytic astrocytoma, always check for leptomeningeal enhancement, because those can have sometimes leptomeningeal dissemination. And I was like shocked by that fact, because those are grade 1 tumors, they're benign tumors. Well, this tumor, which is the high-grade astrocytoma with pyloid features, guess what? Looks like pilocytic astrocytoma on histology. But it has a way different prognosis and biological behavior. And the way to tell them apart is by running all these molecular abnormalities. So, and perhaps the most important one is the DNA methylation pattern. So it is very hard for us to make this diagnosis out of MRI, you know, but it's always good to have in mind that these lesions exist. So this is to close. So this is a summary. So we have a diffuse glioma. We have to think of adult type and pediatric type. In the adult type, the first player is the IDH status, and then you have IDH mutant or IDH wild type disease, and then you have like additional steps there. And then you can call, if IDH mutant, either an oligo or an astro, and if IDH wild type, a glioblastoma, okay? For pediatric tumors, you have either low grade or high grade, depending on histology. And then you have these 4 entities that you can diagnose after following a few steps, additional steps, or high grade entities here. And the circumscribed gliomas, which is a different business as compared to diffuse gliomas, you have the all good ones, the ones that we know, but there are new tumors like the astroblastoma. There is a great paper in neurographics from last year, and they show a few cases of astroblastoma. Beautiful paper. I would like you to go and take a look. And the high grade astrocytoma with pilot features, which is like the gang brother of the good pilocytic astrocytoma. So you may say, hey guys, do we really need this? So all these patients will end up in surgery and chemo rats, etc. So this is a great paper by a big group, including Dr. Jason Hughes, which is one of the brilliant neuropathologists at MD Anderson where I trained. And they published this in 2019 in Neuro-Oncology about the medical necessity of advanced molecular testing in the diagnosis of brain tumor patients. And they say that, yes, these tests are expensive, but they are not as expensive in the long run as in necessary treatments, and life expectancy and patient well-being, as you would think. So, and the more you use it, and when you get mass production of these tests, then they become cheaper, like technology, right? Like everything in technology. So there is a big push from the academic centers to make it to make this standard of care practice. And nowadays, IDH testing, 1p19q testing, ATRX, P53, all of that is standard of care in the United States. And I hope that it is going to come soon or is already there in your countries. So the conclusions is that the diagnosis and grading of the brain tumors of the gliomas is no longer an exclusive function of histology, but a combination of histology and molecular profiling, right? The 5th edition of the WHO classification of gliomas groups the gliomas into 3 big groups, and these can be split into 2 groups, high grade and low grades. And there is simplification of the adult type gliomas only in 3 entities, and these are the main molecular drivers for the adult gliomas. The T2 flare mismatch sign is your opportunity to shine in your reports and is 100% specific for astrocytoma IDH mutant. And in pediatric tumors, always consider the histone 3 mutations, the high-grade pilocytic astrocytoma or the high-grade astrocytoma of the pilot features is something that you have to know that now exists. And besides, this is perhaps the most important, besides the T2 flare mismatch sign, there is no imaging findings that are specific for any molecular abnormality. However, based on the patient's age, tumor location, imaging appearance, you can just give the pathologist and the neurosurgeon a hint of what you think the differential diagnosis is. So I want to thank you, my mentors, and for these cases, most of these cases are from MD Anderson, UT Houston, and a few from here. So if you happen to have any question or any feedback, I'm more than happy to have it. This is my email account. I don't know if we have a few minutes for questions.
Yes, thank you, Dr. Arevalo Espejo. Yes, now at this time, we'll start answering some questions. If you have any questions, please put them inside of the question or Q&A box. It looks like we have one already from Dr. Azalea Garza Bays. The question is, so spectroscopy and perfusion are not going to be useful for grading a tumor?
That is an excellent question, and thank you very much for asking it. And I think that the way I see things is that there is going to be an explosion of new knowledge about imaging biomarkers of brain tumors as we understand the not only the pathophysiology, but also the molecular drivers and the histological features. And one of the examples is the T2-FLAIR mismatch. It came to light after the 2016 classification that defined IDH mutant astrocytomas as an entity, because then you start to think about the brain tumors in a different way, and then you as a radiologist start finding patterns of associations. And it not only includes the standard imaging, but also the advanced imaging. And I think there is a very, very good example for that, and is when you have the IDH mutation, you know that the isocitrate dehydrogenase molecule has 3 isoforms, one which is cytoplasmatic, and the other 2 ones are mitochondrial. And that is one of the molecules that you have in your Krebs cycle. And the normal molecule gives you hydroxyglutarate. And I remember that from my step 1, I remember that with a lot of pain and PTSD, right? I thought I was gonna get rid of the Krebs cycle as soon as I got into radiology, but no, it is here, okay? So when you have the IDH mutation, you have an abnormal metabolite, which is the 2-hydroxyglutarate. That is an abnormal one. And you can identify it with a short TEMR spectroscopy, pre-surgically. So there is a lot of debate about it, whether it's clinically relevant or not, because the patient is gonna end up in surgery anyway. So, but to summarize, to reply to that question, I think it is the opposite. It is going to be even more important, and we are going to have to find new findings and new peaks in MR spectroscopy, new techniques to keep up with the advance of the neuro-oncology and neuropathology field. So I think that is our due diligence, to keep us updated about that. But this is going to be a big thing in the future. So yeah, it is going to be even more useful than it is today.
Excellent, thank you. There are currently no other questions at the time. Let's see.
Yeah, I know that you get kind of numbed when you get a lot of genes and stuff, and we are radiologists, right? We like pictures. So this is just like a way for you to become sensitized to this topic, so you can just read it a little bit more about it. I have to read a lot, and to be honest, I have to, to spend a lot of hours trying to understand this, because it's not my field. But yeah. Any other question?
Not at the moment. All right, if that concludes your questions, then I believe we're at the conclusion of our grand rounds. Thank you, Dr. Arevalo Espejo. That was an excellent lecture. I believe that's all. Thank you.
Well, thank you very much for having me. If you happen to have any question later on after we are offline, this is my email account. You can send it to me, and I will be more than happy to answer your question. If I don't know, please just to Google it up, and do a PubMed search and find it out. But thank you very much.
Thank you. And once again, this lecture will be uploaded to the Health for the World YouTube channel and Academy website in a few days. So if you'd like to watch again, then feel free to join us at that time. Thank you.
Thank you, everybody.